This video demonstrates the technique of laparoscopy assisted Duhamel pull-through for Hirschsprung's disease. The patient was an 8-month-old boy with rectosigmoid Hirschsprung's disease, and a junctional colostomy had been performed at birth. The three ports used were an umbilical trocar for the telescope, a right abdominal trocar, and a left abdominal trocar situated adjacent to the junctional colostomy for the hand instruments. And here you see a large fecoloma in the distal sigmoid colon, which, as we all know, is usually arrested at the site of the transition zone. Another feature that was of interest was that the colostomy prolapsed, and this is the large fecoloma at the transition zone, beyond which you can see the narrow rectosigmoid heading into the pelvis. The prolapsed distal limb could be brought into the abdomen by traction. Polar coagulating instrument for this procedure. Typically, if there was a fecoloma in the distal limb, it would perhaps be an indication to convert to an open procedure. But as you will see later on, the fecoloma created minor, though not any major inconvenience of the distal sigmoid and rectum, and you can see the ureter shining through there. Therefore, the mesentery is lifted away for it to be coagulated and cut. Just there, that's the ureter. The dissection on the left side of the sigmoid and rectum, and from one side to the other. And the first blood vessel to bleed. These vessels tend to retract into the mesentery, so it is better to keep dissecting until the bleeding point comes clearly into view, and it can then be coagulated under direct vision. So as you can see, the bleeding point is now becoming visible in the form of a small spurter, and that can be coagulated comfortably using the cautery hook. So as you can see, the distal limb of the colostomy is drawn up into the abdomen, and this brings a little more of its mesentery into the working area. After completing the intra-abdominal component of the dissection, it is now time to mobilize the colostomy. Now, on inspecting the bowel, we found that the colostomy was too far proximal. Therefore, the decision was taken to close the colostomy and perform the resection 5 to 7 centimeters distal to it. So there you can see the colostomy being closed with a single extramucosal layer of interrupted polygalactin sutures. Having finished the closure of the colostomy, it is now time to decide the line of section. Then, using the index finger through the colostomy incision, see the tip protruding. A gauze pledget on a forceps is then inserted into this tunnel, and the posterior wall of the rectum being divided here. You can see the gauze getting protruded. Stay sutures are placed in the two corners and the anterior and posterior edges of this incision to keep the edges in view. forceps coming in, the proximal colon being fed into it, and the anastomosis is now performed between the end of the proximal normal colon and the edges of the incision in the posterior wall of the anal canal. Once the anastomosis is complete, we just make a trial fitting of the stapler. This is a 75mm linear cutter, just testing that one of the blades goes above and the other below the anastomosis to join the proximal colon and the rectum together. Once the anastomosis has been checked, it's time to cut all the stay sutures away and allow it to retract back inside the anus. At the colostomy incision, we now have to remove the remaining part of the distal sigmoid and the upper part of the aganglionic rectum, and this is done by strong traction medially on the colostomy incision, which allows us to place another linear cutter as close to the top level of the colorectal anastomosis. The linear cutter is applied and fired, leaving a small amount of rectal stump and completing the Duhamel operation. All that remains to be done now is closure of the colostomy incision, and that completes the procedure. The child was kept on antibiotics for 5 days post-op. He had an uneventful recovery and has been followed up for 4 months without any problems. Thank you.